Greetings from Digital Team Indian Medical Association. I am Dr. K K Aggarwal, National President-elect Indian Medical Association and President Heart Care Foundation of India. Today we have a guest interaction with Dr. Sameer Mehta, who is from US, from the Global Human Foundation, who is working tirelessly for the last many decades on the issue of acute myocardial infarction management and reducing its mortality and morbidity all over the world. IMA thought of interacting with him. Dr. V.K. Monga will be interacting with him in great detail. I have had a couple of meetings with him, and IMA is initiating a lot of discussions and a lot of projects with him in the field of acute MI, reducing mortality and morbidity. It goes back in 1983 when I came back to Delhi, and in my medical college we hardly used to see acute MI cases, but when I entered Delhi in 1983 December, it was flooded with cases with acute MI, and we were the first one to start septokinase therapy in Delhi way back in 1983 December, and then in 84 in July we presented the first data of septokinase. And then came the era of primary PCI, and that has totally revolutionized the management of acute myocardial infarction. Today, most of the people think that a successful acute myocardial infarction treatment is that the patient is saved. The answer is no. We don't only have to save him, we also have to preserve the myocardium, because time is muscle. Therefore, we need to reduce not only mortality but also morbidity. Now, if you don't treat a patient of acute MI, the mortality may be 13 to 14%, but if you treat a patient with acute MI within minutes, then you may reduce the mortality to 1%. Otherwise, if you are delaying the treatment, the mortality can be 7 to 8%. So the importance is to treat the patient as early as possible. Therefore, a facility for acute MI has to be 24/7. Unfortunately, Medical Council of India says you cannot advertise, but IMA is fighting that it is the duty of the medical profession to inform the public that for acute MI cases 24/7 facilities are available, and if available, at what places. Every place may not have 24/7 facility. Same is true for paralysis. Therefore, where emergency medical treatment is available and surveillances are available 24/7, we need to treat such patients as early as possible with primary PCI. Only in those cases where primary PCI is not available, not feasible, you can go for pharmacovigilance, giving them tenecteplase followed by angiography within 24 hours. So the basic management therefore is, wherever possible, effort should be made to provide primary PCI as early as possible within minutes, within 3 hours, within 90 minutes, the PCI procedure should be done. And that's what the most important thing is. Now, with our Honorable Chief Minister Jayalalitha's death, another avenue has come. Up till now, the management of acute MI, if the patient has gone into cardiac arrest, it was CPR followed by defibrillation and emergency angioplasty, and if required, intra-aortic balloon. And with now ECMO taking place as a head news and all over the newspapers, public will start demanding, every patient of cardiac arrest will start demanding that why ECMO has not been done on me. Time has come for us to educate the society, the public, and I particularly feel that ECMO facilities will increase in the country. I just inquired yesterday in Max how much ECMO costs. This is 3 lakh per insertion. That means if you use ECMO, the patient will be billed for 3 lakh extra, which is not a very high amount in a tertiary care hospital. Therefore, every tertiary care hospital, acute management of acute MI, and if you have ECMO, if you have bypass surgery available, your mortality should be less than 1%. Any chest pain, any burning in the chest after the age of 40, appearing for the first time in life, is acute MI unless proved otherwise. Any shortness of breath occurring for the first time in life after the age of 40 is cardiac asthma due to acute MI unless proved otherwise. Therefore, we need to never ignore early morning chest pain, discomfort in the center of the chest. Any chest pain lasting less than 30 seconds is not a cardiac pain. And any chest pain which can be localized with a pinpoint finger is not a cardiac pain. So after the age of 40, if there are risk factors, and if you find a burning in the chest, you can chest pain, breathlessness, easiness, restlessness, rule out coronary artery disease in such cases. And when in doubt, you may have to go for a CT angio to rule out underlying coronary artery disease. If a patient comes to you with acute MI, your job is to give him immediately 300 milligram of water-soluble aspirin to chew. That alone can reduce mortality by 22%. And if available, they should also be given 600 milligram of clopidogrel, 80 milligram of atorvastatin, beta blocker as the case may be, depending upon the tachycardia present, and oxygen, some sedation, and these patients should be shifted as early as possible to the nearest PCI center where facilities are available 24/7. Remember what I am saying. If PCI facilities are available only in the day, there is no point sending them in the night because time is muscle. We need to give them PCI within 90 minutes of reaching. And in most of the places where facilities are not available 24/7, it may not be possible to do PCI. Now, whenever there are patients who are scheduled for angiography or PCI and routine stenting, and if a patient requires primary, we always take precedence over other cases. That means it's a right. You can postpone other PCI cases, other stenting cases. You have to take care of an acute MI case. Now, never ignore acute MI in elderly. PCI can be done at any age, whether it is 90, 80, 70 or 60, whether it is a male or female. And even in younger people less than 40 years of age, start suspecting it may be coronary, do an EKG, do a drop eye test, and do an echocardiogram. And if you find you are suspecting, go for either a 64 CT or an angiography to rule out acute MI. So therefore, acute MI management is high degree of suspicion. Most of the time, these cases are missed in the night, and they develop primary arrhythmia and they die. And what happens is a person gets restlessness in the night, breathlessness in the night, or a mild chest discomfort or a burning, and they try to ignore. Even if they go to the hospital, they may not find the ECG changes because the ECG may be normal in the first 6 hours. Therefore, if you have tachycardia, unproportionate tachycardia at 2 o'clock in the night, it may be an oncoming acute myocardial infarction. That's all what I wanted to say, and let's now have Dr. V.K. Monga, our Dean IMA CGP, and the forthcoming IMA Finance Secretary interacting with Dr. Sameer Mehta. We'll be back with another show after this next week.
You have Lumen Global as an organization with you. What is it?
Vinod, first of all, thank you so much for inviting me, for interviewing. I can only hope that the next 20-30 minutes which we spend is meaningful for members of the Indian Medical Association. And congratulations also to Dr. K K Aggarwal, whom I have known for almost the last 20 years. I think the Indian Medical Association is in very capable hands. He's a very passionate man, and there is no issue as far as I am concerned about saving lives from heart attacks. I have devoted almost my last 16, 17 years of my professional careers. I think I am the world's only cardiologist who does primary angioplasty for a living. Nothing else. I don't do anything else. Everything in my life. I used to be the chief of interventional cardiology in one of America's biggest programs. But over the last 16 years precisely, all I have done is angioplasty for a patient having a heart attack, which is primary angioplasty. And Lumen Global is a organization we created. It's Lumen Global is the meeting which educates people about taking care of a patient with a heart attack. And the Lumen Foundation is a much bigger, larger organization which is helping patient awareness, and at the moment it's involved in 32 countries. It is helping create heart attack networks. It is helping teach interventional cardiologists how to do a procedure better. It is helping the common patient. It is helping the general physician. So that is what we have been doing, and I think so far as I'm concerned, I'll give you my absolutely honest perspective. In 2016, we know that it should bother our conscience as a doctor that a patient dies from a heart attack. And in India, you have a 30-year-old die from a heart attack, and it is absolutely unacceptable to us as doctors. I think If we consider this to be our loved one, to be hearing stories that a 30, 35-year-old died from something which takes me 9.2 minutes is my average now after 16 years. And I'm not at all bragging. There are many, many talented interventional cardiologists who can do the same. When you take care of a patient with a heart attack, there are two challenges. The easy challenge is you get me the patient. It's very easy for me to do it. Mm-hmm. The harder thing is to get the patient to the right place, which is the process.
At the right time, you know.
Right. That is what Lumen Global and the Lumen Foundation tries to do, is to help you develop, because you cannot compare New Delhi with New York. It's totally different. The challenges you have here are far greater. The patients are presenting much later. Yeah. There are other system delays. There are infrastructure problems. There are problems with the insurance. There are problems with the payment. The patient's consent is delayed as a result of all these. So these are some issues which our next Lumen Global meeting, we've held it, this is going to be the 16th year of the annual meeting. The meeting will be held February 25 and 26th in Jaipur. And we chose Jaipur because I have created a heart attack program for the entire state of Rajasthan. Mm-hmm. It's known as Rahat, Rajasthan Heart Attack Treatment. And with that, we can virtually reduce the gaps, the barriers, the obstacles, and improve both the heart attack process and the procedure.
I think, Amit, you have talked a good amount on your foundation. How did, even great things start with a scratch, you start thinking about something and then it becomes big. How did you think about it 16 or 20 years back, that this will assume such a big proportion and you will be a pioneer in this? How did it come to your mind that time?
Such a nice question. So, I used to be the chief of interventional cardiology. I had 48 interventional cardiologists who worked under us. It became one of the busiest programs in the country. And those years, I was doing some primary angioplasty. I had done, to be precise, 137 of those. Mm-hmm. And we knew it worked, but there was something missing. Something was missing. We were doing primary angioplasty like how it is being done in parts of India. If the patient comes, if you're available, if the team is available, you do it and you see the miracle. Somewhere around that time, this is 1999, the American Heart Association and the American College of Cardiology, they got together and they connected this missing link. The missing link is what we today call it as a door to balloon time. What they did was, they said, look, primary angioplasty truly works if you do it fast, if you do it very early. And early enough that we used to even monitor the time it took from the patient to walk through the door of the emergency room to doing the angioplasty, door to balloon time. As soon as that hit, it struck me that, look, now we have got not only a predictable procedure, now we've got a goal. Now we've got a clear parameter that every patient who comes, we are going to do it. And the more I started getting involved, the magic of angioplasty was always evident. Now we had a predictability to it. We were able to control it. We had a clear parameter how we could measure. And I'm glad that I sensed this was a calling in life. I had absolutely no doubt. Angioplasty is beautiful, but angioplasty done for primary PCI, where you have a patient who's coming, crashing to you with such incredible crushing chest pain. People talk about heart attacks. They describe a heart attack like how I just described, crushing chest pain. They go, no. Almost all of them are afraid they are going to die. Yeah. And so many of them die. You take this patient and 10 minutes later, you completely fix the artery, you put in a stent there. There is an excellent flow, the artery looks perfect, but not only that, the left ventricular function has been preserved.
That is more important.
To my friends, sometimes, Vinod, I tell them that I've started developing a schizophrenic personality. So it's been 16 years, night after night, The family has seen me abandon everything, run to the hospital. I've had accidents, I've had tickets and needed to go to courts to defend myself. And so 3 in the night, I'll be going back next week. Almost every day when I'm in Miami, I'm on call at the hospital. So 3 in the night, they'll call me. So what do you think? I wake up and say, thank you God? No. I'm saying, I'm exhausted. I cannot do it anymore. And but I've had the same discipline. It has never taken me more than 2 minutes to leave my house. Never.
Okay.
The car is parked facing the street. I drive 90, 100 miles an hour. It's every minute is precious. If it is your loved one who's having a heart attack, you don't want me to open his artery in 90 minutes. You want it 80 minutes, 70 minutes, 60 minutes, as fast as you can. So then I'm leaving the house. This is one part of my schizophrenic personality. You're exhausted, you're tired. You're saying that I can't do it anymore. Then I go there, and often when I'm 2 in the night, I'm running. Most of the patients are still male. You look at the wife, you see the family, they are so scared. I know. And then you go there and you do this incredible procedure, 10 minutes,
and then
12
come
minutes.
out in 10 minutes,
And then
everything is relaxed.
there are times I have gone to the room, shut the room and fallen on my knees and thank God that, wow, what a blessing. So the second part of the schizophrenic is when I'm driving home. I'm saying this is unbelievable. This is the beauty of angioplasty. This is what I always wanted to do in life. And I'm glad that, I followed my conscience. When I started doing it, there is a funny story I can tell you, many years later. We used to do this at a hospital, it's right outside Miami. It's known as Memorial Regional Hospital. 2 cardiologists there, they had made a bet. They said he'll give it up in 3 weeks. Yeah, he can't do it more than that. It's been 16 years. 16 years, I have gone to court 50 times. I've had 5 accidents, I could have been killed in one of them. I'm in excellent health because I'm happy. It's a wonderful procedure. I gave up internal medicine, I gave up cardiology, I gave up angioplasty, and it's been one wonderful opportunity to save lives. It's over the years, it's been a fantastic chance to train thousands of physicians all over the world. And I'm glad that, when I go to a meeting and tell a doctor that, look, at 3 in the night, you have to run and do it, I think most of them do it because they know that I have done it.
I think it's great. It's great. At least I'm so thrilled, talking to him. Okay, Sameer, you have worked in US, you have worked in India, you are born here, you know the realities of Indian conditions and Indian patients also. How would you compare, if you talk about the percentage of people getting it in India, the type of heart attack we have, the type of heart attacks US people have, and then the treatment facilities you talked about it, they are very difficult here in India. But overall, heart attack scene, how would you compare India versus US?
So, in this, there is a good news and a bad news. Let me give you the bad news first. The bad news is that the Indian patient is a 35-year-old male,
Yes.
who's got a culprit lesion which is causing the heart attack. He's got additional disease because of the metabolic syndrome you have in India, which is an epidemic.
Yeah.
And he's already got impaired left ventricular function.
By the time he reaches hospital.
If that is not bad enough, he doesn't have money. And you have a system which is not able to pay for it. This is a tragedy.
Yeah.
So this is India. This is heart attacks in India. When people talk to me about, we have got a wonderful group of directors who help with the Lumen Foundation, some of the brightest and the most committed cardiologists in the world, I tell them the real frontier, the real challenge is India because of young people, severe disease, impaired LV function, no facilities, no money. This is the challenge. That's the bad news. Let me give you the good news now. Like the patient who's 35-year-old, the interventional cardiologist in India is a 35-year-old, sincere, hardworking person who's working his heart out without resources, and he's happy and willing to do it. All I have to come and train these people. The rest you'll be able to do it.
I think yes, and then the number of hospitals in India that they are doing PCA or angioplasty, I think it's growing by the day, and even in small district hospitals nowadays, the facilities are available. But as you rightly said, the resources are not with every person. I mean, insurance sector is not really that great as it is in US. So, but still, okay, I think we have to wait for a few more years to achieve that level. Now coming to the technical part of it. There is still a controversy that in acute pain within 1 hour, 2 hours, 3 hours, you reach the hospital. Then still some people want that it should be thrombolized, it should be given a treatment in a smaller setup, and then shifted to a bigger hospital for angiography and plastic, whatever is required. But some people say that the results are better if you send the patient directly to a place where all these facilities are available. And there are some people who are in favor of saying this, that the results of primary angioplasty and the results of thrombolysis are almost the same. So why take a risk of sending the patient to a far off place and spending a lot of money at the same time when the patient has pain? He may not have the money also, and time may be running against him. So I think these are a few issues which a GP, people come to a GP at the first instance. I mean, for example, I am a GP. Any pain anywhere in the body, my family will come to me and talk to me first before they go to a cardiologist or a internal medicine person. So what is your take today? Angioplasty, primary angioplasty versus thrombolysis.
Excellent. So let's first of all, before I answer that question, let's talk about something even more critical, what you just mentioned. When a patient has a heart attack, first of all, most patients don't even know they are having a heart attack. I've had interventional cardiologists who were having a heart attack and they were seeing patients.
In India, at least most of the time, we blame the gas in the tummy much more than the pain because of the heart.
When a patient is having a heart attack, every survey, every follow-up in just about every country I have gone, and I have done my share of training doctors in many countries, most of the time they call either a relative or their primary doctor, their general physician. To me, that is paramount. If you understand here, what's the first step? A life of a patient is going to be saved. Interventional cardiologist and angioplasty comes much later. The decision about thrombolytic therapy and angioplasty comes as the next. The first part is that I have to educate the general physician. The general physician has to be able to diagnose this is a heart attack. He needs to understand, look, is this something which is very severe? Is it something which is not so severe? He has to initiate some initial treatment and guide the patient into the right place. That to me is paramount. Now let's go into thrombolysis versus PCR. If your loved one is having a heart attack, believe me, you want him to have an angioplasty. Now, this is the trade-off. You've got a possibility of doing angioplasty, which we know has the best results, but it is not available in a majority of the places. I've been doing a lot of work in South America, in Brazil, Colombia, and Chile. 8% of the hospitals provide angioplasty, and less than 10 or 12% of the people have access to angioplasty. I think in India the number is even lower.
Yes.
So then, what should you do? So another very attractive possibility is to give thrombolytic therapy. Again, the real way to give it is pre-hospital.
Okay.
I know pre-hospital is very difficult to do most of the time, but as early as possible. In angioplasty, we have a parameter door to balloon time, I told you, 90 minutes. Same way, thrombolytic therapy, door to needle time is 30 minutes. Now, is there an absolute at 30 or something that the mortality has some dramatic change? No. But the principle is clear, every minute counts. Now, how do the two scientifically compare, I think, is the real question you are talking about, which helps you answer which to use one, which is better. Thrombolysis works the best in the first 2 to 3 hours. And that's the data from the STREAM trial which was done. I don't want to make it harder for a general physician who may be listening to it. All they need to know that this was a very nicely performed trial, STREAM trial, which basically compared a group of patients who got thrombolysis very early versus primary PCI. And again, if you are able to use thrombolytic therapy very early, the results are excellent. But that's where the problem is. We also know from a very powerful registry in India known as the CREATE registry. And more recently there has been work also from the Kerala registry and some other recent papers which have looked at Himachal Pradesh, the Northeast. An average patient in India, when they are presenting with a heart attack, it's already 6 hours. So at 6 hours, the role of thrombolytic therapy gets less. I mean, the window, as per the guidelines, we can still use it for 12 hours, but we also know that the role is going to be much less. Particularly if the agent you're using is streptokinase, then it is probably going to do more harm than good. So what is my recommendation? What is the recommendation actually as per the guidelines? Is that if a patient has had very recent symptoms, 2 hours, 3 hours, if he's presenting where you don't have angioplasty, thrombolytic should be the first line of treatment. The problem I have is something else. Any hospital in the country which does angioplasty, and in New Delhi, you have more cath labs in New Delhi than in any city in America. Okay? As far as I know, there are 73 cath labs in New Delhi area which are doing angioplasty. Okay? So the problem is, if you have these cath labs, in Kerala they have 102 cath labs. I mean, the whole state has tons of cath labs. It's become a very nice, lucrative business also to run. Let's be honest about it. You can do things for philanthropy up to a purpose, but if there is money to be made, I have no problem. But here is the problem. We know today primary PCI is definitely the best treatment, except for that patient who presents very early. Everything else, primary angioplasty is better. How can you in a Delhi, in the capital here, a patient comes, he presents with a heart attack, and instead of taking him immediately to the cath lab, in the night they are giving thrombolytic therapy, during the day they do angioplasty. I think that practice has to stop immediately. So if you have a cath lab, I think it should be a moral obligation, given the dramatic difference, the dramatic improvement in mortality, the saving of the left ventricular function, that any patient who presents to a hospital with a cath lab must not get thrombolytic therapy, he must get angioplasty then and there. And that, once you understand that, the number of patients who would be treated with angioplasty, the number of lives which would be saved, the number of people who will have the normalization of their left ventricular function will dramatically rise. Now, if you're out in the periphery, there is no cath lab available. We have this concept, we call it pharmacoinvasive, that the patient is initially given maybe half a bolus of thrombolytic therapy, and we move him urgently. Now, all these issues are fine. There is one other missing link which I think is very important. And over the last few years, there are two next chapters to my own research work in angioplasty. One relates to telemedicine, and the other is taking care of women. Women have worse outcomes than men with heart attacks. And that is because their presentation with a heart attack is delayed. And we also realize today, this is the work of the organization I've created, it's known as GLOW, Global Lumen Organization for Women. We understand that there are 5 specific barriers women face. Personal barriers, social, cultural, financial, and religious. As a result of it, women are presenting late. Because they are presenting late, their outcomes are, as it is women during angioplasty, their vessels are small, there is more bleeding. So it's just not, we cannot accept that our mothers and sisters are being held to a different standard. The second thing, which also I think has a huge possibility in India, where there is a shortage of cath labs, shortage of cardiologists, a very large country, is the role of telemedicine. In Brazil and Colombia, and we are also starting this in Mexico in the next few weeks, and Chile, these are the 4 countries I have created. It's a program known as Latin America Telemedicine Infarct Network. 122 active heart attack centers in Colombia, which is a very hilly, very beautiful country, hilly regions, very remote jungles. 42% of the whole country's population has been covered with the program I have created. And a patient who goes to a very small clinic, we are able to, in 5 minutes, we are able to give him an excellent, accurate diagnosis and move him for either thrombolytic therapy or angioplasty. The program I mentioned to you in Rajasthan, Rahat, is also using telemedicine as one of the ways. I think that's a possibility which some parts of India, I think, should consider.
People are talking about it, and at some places, I mean, they have started as a project also. So telemedicine in diagnosis of heart attack and then management, I think it should go a long way. And then, let's talk about the position of ambulances in India.
Yes.
That's a big hurdle. We were told that ambulance has at least 4 parts, and even the simple one. The career, the infrastructure, the people manning it, and 4th is the communication. These are the 4 components of a good ambulance. Career, government ambulances 50% are down, 50% they may be working and etc. Then you talk about the infrastructure, most of them may not have even an oxygen cylinder with them. Third condition is the manpower in an ambulance, and ward boy or a staff nurse goes with that, and they don't know anything about the heart patient, what to do on the way. And the 4th is communication. They may have their own mobile phones, whatever, but is not qualified enough to talk to a hospital person where the patient is being shifted. In US, the conditions are different. There is every minute report of a ambulance carrying a patient, the paramedical staff or medical staff accompanying them, and the hospital to which the patient has been referred. I think these are big issues which may take longer, or you would like to comment upon them?
Absolutely, I want to comment on that. So, the ambulance which you mentioned with the 4 major deficits, it's not an ambulance, it's a medical taxi. That's what it is.
Sir, you're right.
The problem with that is not only that is not doing the service, it is actually doing a disservice, because it raises the expectations which are not delivered. Now people think they are waiting, they are having a heart attack, every minute is counting, and now they are waiting, they have the expectation that an ambulance will take them to the hospital and their life would be saved. Instead, you have a ill-equipped something which is not so. You're exactly right. Now, another concept you have to understand, if a patient with a heart attack waits for the treatment till he reaches the hospital, it's already too late.
Yeah.
Almost everything which the Lumen Foundation does, which I try to teach in all these countries, is the pre-hospital care. And it is the pre-hospital care which starts even with the patient. One of the textbooks I've written is Preparing for Your Heart Attack and Surviving It, of course. And that is teaching people about patient education. This is what your general physicians need to understand. It is this part where patients should recognize, see, when you're having a chest pain could be anxiety. Chest pain could be, as you mentioned, gas. Chest pain could be costochondritis. Chest pain could be pulmonary disease.
A number of reasons, yeah.
But a chest pain in a diabetic who's smoking is a heart attack. Okay? So you have to understand, people need to figure that out. If you teach the patients, if you educate them enough that, look, this I think is a heart attack, and you choose an aspirin, and before he's falling or doing something else, chances are he'll survive. But the next level, I truly believe that if you can educate the general physician who can initiate, I think that is half the battle won. Now, it will be many years, I understand, before India would have a reliable, what we call it, a centralized ambulance system. So in America, one of the battles which we won, and it was not an easy battle, I know it because I was involved many years and we did not succeed many years, is that we did two things. We actually learned heart attack treatment initially from Denmark and Sweden, and then adopted it so quickly. So United States did two things which I think are, at the moment now, the best place to have a heart attack is America. That's a terrible thing to say, but chances are your life will be saved there. Why? Because we did two things. Every hospital by law in the United States is now designated as a PCI capable or PCI non-capable. So now you've got a clear networking. Every community has developed, now this is an American Heart Association guideline, category 1, that every community will develop a STEMI, ST elevation myocardial infarction network. System care we call it. So if there are two PCI hospitals, the other non-PCI hospitals are connected. That's one change we made. The second change was even more difficult. Just imagine, in the United States, we have a fantastic ambulance system. Excellent. Well funded, well run, well trained. Still not as good as Denmark. But Denmark is a small country. United States, to do it in a whole country, that 92% of the population, in 5 minutes they have a well-trained ambulance, you call it. But here was the problem. An ambulance used to pick a patient with a heart attack and take him to the nearest hospital. Now they don't do it. They take it to a PCI hospital. So when a patient is picked up with a heart attack, he's taken to a PCI hospital. This saves time and life. This is what your patients need to know. This is what I am going to educate the general physicians here, is that they need to know. If a patient is having a heart attack, you don't take him to a place where they don't treat. He has to be taken to a specialized hospital. Maybe, look, we understand medical ethics. Advertisement is not something which we do. This is trying to educate the people by informing them where is heart attack treatment available. I think something like that is important. But it is absolutely essential. And once you start investing in the ambulance system, I mean what? There are three biggest causes of death all over the world: stroke, heart attacks, and accidents. Ambulance system helps in all three.
Yes. So, Dr. Sameer, we have talked about these things that are available here and there. Now, you are talking about awareness in public and the GPs also. GPs are equally to be educated on these issues. Because unless a GP is involved, how can he attend a patient? How can he diagnose the patient at the first go? What more are you doing for, maybe we talk about Indian GPs, in addition to the public that you are making them more aware?
Right. So what you have to do is that it happens at numerous levels. I've been associated with the Delhi Medical Association, Indian Medical Association. Each time I come, I speak to your members. This itself is going to educate people. I write very often in the Indian journals, in the Indian Heart Journal. I have conducted several dozens, maybe more than many dozens. It's been almost 15, 20 years. I've gone to 20, 25, 30 cities, help them create heart attack programs. In a few hospitals in Delhi, I used to hold a boot camp. So here is a funny story. This will make it so much easier for you. So in Miami, I used to have my own blood to balloon time. I maintain a compulsive, rigid, beautiful database. Every patient has been meticulously entered there. When you kindly introduced me as the person who has possibly done the most angioplasty, you have to understand this is not with fellows. No. Every patient, I have stuck the groin and I have removed the sheets and I have entered the data. When we started collecting it's known as the Sincere database.
Okay.
And I called it Sincere Single Individual Community Experience Registry. And it was also because it was a sincere endeavor. I promised myself 16 years ago I would never take a penny from industry. This was my sincere work and it has always remained that way. Today's Sincere database now has got 73 data points which I have entered, 73,000, sorry. And that is the source of the 5 books which I have written, all coming from the data. When you start doing this, there is the compulsiveness which is entered along how it is captured, yields many teaching points. Now I know exactly where the delay used to happen. So my database showed that my door to balloon time was 68 minutes. And there is a famous hospital in Delhi, they were touting that they used to have door to balloon times of 21 minutes, 22 minutes, and talking in Hindi, humne धूप में बाल सेंगे. So I did a boot camp in their hospital. It's a famous hospital in Delhi. And I slept there 3 nights. I used to do these boot camps. I used to go and sleep in a hospital for 3 nights. I've done it in China, did it in India, did it in Russia, in a hospital in Indonesia. That was not a very good experience for other reasons. So I used to do that. So we had a patient come to this hospital at 11:30 in the night, and here he is, the patient is crashing. And this is the hospital talking about door to balloon time, 22 minutes, and now you have a patient. So I said, what's happening? They said, oh, वो तो barber आएगा पहले, नहीं आएगा, उसने groin shave करना है. I said, so 11:30 in the night, with the patient crashing, you're waiting for a barber to come and shave the groin. I mean, this is how. So they were, their door to balloon time was counting from the moment the patient was on the table till the procedure is done. But that's not how it is. There's another very sad story I'll tell you, because I've often thought about it. God has given me, the enough humility that I learned from it. I have never, when I see the Indian interventional cardiologists, doctors work in such difficult conditions, my job is very easy in America, believe me, very easy. The hardest angioplasty I have to do is something technically. Almost each patient I go there, the patient is ready, I just have to do a technical procedure. In India, at 3 in the night, you are trying to convince the patient's family, and they are trying to figure out who's going to pay for it. It is a challenge you have.
It's a big issue.
So, Ahmedabad mein the, and we did this patient which has got such a, I tell the story all over about how hard it is to do angioplasty in India. And there are so many local factors which are so strange. I mean, the chaos which is persistent in India, and you have to understand, just look at what is happening with the demonetization. And I mean, today I went and I had some 36,000 rupees lying here. So I went there to put it in the bank and spent the whole day doing that.
Were you able to do it?
I was able to do it, but it was suffering. You see the poor people.
Well, I think it's a temporary phase. It will be long.
So, but there is, in life, in fact, Indians thrive in chaos. But chaos is not a great thing to have when you're having a heart attack. So here is this patient in Ahmedabad having a heart attack. So patient is having a heart attack, so the family is there now. The family is getting the money and whatever it is, and so now this hospital, the cath lab has finally come. The patient is having chest pain. I'm there in the ER. We've given him a little morphine. We've given him a bolus of lidocaine, antiplatelets, and now we are waiting for the elevator. So it took about 5 or 6 minutes for the elevator to come, and the first one was busy. So the team said that आप बाहर आ जाइए, इनको ले जाने पहले. They didn't move out. A fight erupted. They went up. Second elevator came after another 3 or 4 minutes. Now they moved the patient in, and now there is a daughter-in-law with that. A phone rings. It is her son calling from Dubai. She says, चाचा जी आपसे बात करना चाहती हैं. आप बात नहीं बात कर लीजिए. And now they close the elevator. As the door is being shut down, she misses the signal. They open the door again. Take the patient back again. He's talking on the phone. He has a VT, VF, and has a cardiac arrest. Can you imagine this? This is so silly. So there's this whole, when I think about this, you understand. Now, of course, we revived the patient, and the angioplasty was done, and he did fine. But every minute counts, and nobody realizes that sometimes. I'll help you understand this in a very different way. Often people have told me, "Yaar, kya kar rakha hai aapne apni zindagi ka yaar? You know, it's look at you. What have you done? I mean, there's no life. You're running around doing all this." And I said, talk to the person whose life I saved, and talk to their family, and then you understand why this is such a beautiful thing. Which somebody has to live this life. Somebody had to do it, and when you asked me initially, you know, why did I start it? Because it's
the big question.
and when you do it,
feeling of achievement. I mean, that's
I just call it a wonderful privilege. I consider myself blessed. It's just I think I understood this better than others, and I practice something which is a magical procedure.
So, friends, here was Sameer Mehta. And in fact, I tell you, I mean, most of the GPs will be watching us. Gone are the days of 70s when a patient of chest pain comes to your hospital, you give only morphine and oxygen and wait for him to recover of his own. And the mortality would be around 40 to 50%. And whosoever were saved, they had a bad time in their life career. And now is the time when people like Dr. Mehta have really worked internationally, and the mortality is less than 1% in best of the hands with the latest gadgets and latest facilities available. So I think we need to be, conscious of the fact that any patient coming to you with a chest pain in the dead of the night or in the morning, you suspect a heart attack, send him to the best possible place and let him see a doctor like Dr. Sameer Mehta. So thank you, Dr. Mehta. We are really obliged for you having come to this show and obliged us. Thank you greatly to us. Thank you.